Hello everyone, welcome back. Today I'll be covering regarding biopsy for musculoskeletal tumor, especially regarding needle biopsy, a few questions answered, a part 3 video. I hope this video will help you in your exam too. Now let's get started. Do all radiological lesions need a biopsy? There are a few exceptions where the imaging leaves no doubt regarding the diagnosis. Examples of bone lesion which can be diagnosed with certainty on imaging include osteoid osteoma, osteochondroma, fibrous cortical defect, and chondromas. Be careful with cartilage lesion. Any growth of osteochondroma is suspected for malignant change and need additional imaging like CT scan and MRI. Any cartilage lesion in long bone which cause bony expansion, periosteal reaction, marrow edema, severe internal scalloping, or cortical break or pathological fracture is suspected for chondrosarcoma except in small bones of hand and feet. This figure illustrates the X-ray and MRI pictures of a chondroid lesion in the distal tibia in a 54-year-old man. The calcification on X-ray and lobular structure on MRI are characteristic of a chondroid lesion. The bony expansion points to a chondrosarcoma rather than an endochondroma. Can a biopsy and final treatment be done in the same setting using a frozen section? As a general rule, it is dangerous to carry out the final treatment on the basis of frozen section diagnosis and is not recommended in certain conditions. The final treatment can be carried out in the same time as biopsy. Example, in unicameral bone cysts (UBC), which are benign and have characteristic appearance on X-ray. Once the needle biopsy confirms the diagnosis from the frozen section, a steroid can be injected through the same needle. For aneurysmal bone cysts, ABC, biopsy should be done as telangiectatic osteosarcoma can mimic ABC. In cases of local recurrence or metastatic disease where the primary diagnosis is known, one may safely proceed with management after a frozen section confirms the diagnosis. Even in the situation of metastasis, in particular solitary metastasis in the proximal femur, a primary tumor like chondrosarcoma must be ruled out by frozen section biopsy prior to final management. What is the accuracy of a needle biopsy? The true cut biopsy for soft tissue tumors around 96% by Kissin M.W. et al. 1986. For closed bone biopsy of bone tumors around 80% by Jeffrey et al. Cartilage et al. Reported equivalent sensitivity and specificity between the needle core and open biopsies of bone. Cartilage et al. In 2030 reported similar accuracy between the incisional biopsy and CT-guided core needle biopsy for musculoskeletal lesion. We can conclude that the needle biopsy yields the same as open biopsy. What part of the tumor should be biopsied? Sarcomas grow centripetally and therefore have viable cells in the periphery. The centers of many rapidly growing tumors are necrotic. So the best material for diagnosis is from the periphery. Biopsy from the soft tissue component of a bone is as representative as that from the bone and does not risk a pathological fracture. Ossified or calcified tissue should be avoided due to less cell present. Lytic area provide the most representative tissue. Techniques for the needle biopsy. A true cup biopsy is done after infiltrating skin with local anesthesia. Too much infiltration can increase the area of contamination. The needle is advanced till it enters the tumor. The trigger is then released and the needle is withdrawn to obtain the core. For bone, the Jamshini needle is advanced through the step incision until the trocar touch the bone. With rotatory motion, the outer cortex is pierced and the trocar is withdrawn. The cannula is further introduced into the bone and rotated to the core to core out the tissue. The cannula is withdrawn and the core removed from the cannula using a stylet. The trocar is replaced in the cannula and the procedure repeated from the same puncture site by slightly changing the angle of approach. The needle should penetrate different areas of the tumor from the same point of entry by changing the angle of approach. Sampling multiple areas reduce the errors of necrotic area sampling, and for sarcomas, it is often heterogeneous. This figure illustrates through the single entity site, the biopsy needle should be directed in multiple directions in order to sample different areas within the tumor. This reduces the sampling error in heterogeneous sarcomas. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.